I'm Katie Flint, if nobody's met me before, and I'm one of the specialist doctors on the palliative medicine team. And I think the plan at the moment is for us to do some of these sessions twice daily, starting today and then throughout next week. And as I'm sure you can appreciate, some of these sessions may change, they may be adapted as new information comes through, given how challenging obviously the current situation is. And I think part of the reason we wanted to do this is there's so much information from so many different providers, and certainly the organisations we work with, we thought some of the information that we're receiving, it might be helpful to share with yourselves. Some of you may not have cared for patients with severe illnesses, including those for end of life, and just to give you a little bit of guidance, support, help with symptom control, and to know who you can ask for advice, really. So we'll talk through some things, and if I could kindly ask if it's okay for questions at the end, because you may find something that you're going to ask may come up, and then we can talk through anything at the end, because I suspect any questions are probably very similar amongst everybody. So as I mentioned, things are clearly changing very quickly, and I don't know about yourselves, but my emails are bombarded daily with different information, different knowledge and guidelines, and certainly from my perspective in palliative medicine, the ones that we've worked with most the last few days has been Hospice UK and the Association of Palliative Medicine. And what they've tried to do is look at ways that we can provide guidance not only for those patients that will sadly become end of life from COVID-19, but also patients who will be very symptomatic, who we hope will survive and improve, but also they will have symptoms that we can also help, even if it's just for a temporary period of time. So I think there's a lot that we can do. So just because we're palliative, there'll be a lot of patients with symptoms that we can still assist with. So certainly Hospice UK and the Association of Palliative Medicine, over the last few days, they've been working very hard to produce guidance. And we were involved in a conference call on Wednesday with about over 250 clinicians in palliative medicine throughout the UK that are all trying to work together and to learn some information from 11 hospices in Italy, what they've learned from their experience and what we can sort of use that information to move forward with. And I think although these sessions were initially, when we designed it, mainly at prescribers, so particularly prescribers because medications are going to be important to help symptoms, clinicians to some degree because they're often the key decision makers about patients' care, about escalation levels of treatment. But I think any information from these sessions will be helpful for everybody, and just to try and provide a bit of reassurance that we are there to help and we can do a lot to assist you all. So the main cause of death, sadly to be expected, is respiratory failure, and that's in about 90% of patients. And respiratory failure looks very similar whatever the cause is. So whether you've cared for a patient with end-stage COPD, pneumonia, motor neurone, the process is very similar. So what I would say is the treatment is very similar to what you may have already experienced in your own clinical areas, but I also appreciate not everybody has managed such patients. Shock, whether that's septic or cardiac shock, again, a large percentage of patients were in that cohort. Myocarditis, not so common, but again, those patients may complain of things like chest pain, particularly angina type chest pain, and those are other symptoms that we can improve in those patients. And then there were some smaller categories, so things like cardiac arrhythmias, renal failure, and some of those smaller causes, we think now, looking back on some of the data, may be potentially due to some of the treatments that understandably countries were trying to use, not knowing how to treat this condition. So symptoms, very much as we would expect in a patient of end-stage respiratory disease of whatever disorder that would be of. So the primary thing, shortness of breath. You will have seen the videos, the footage that has been on social media and the internet and online. People are very breathless. And understandably, when you're breathless, the first thing you do is you panic, you feel anxious, your breathing tightens up, and it's that vicious circle of not being able to get your breath. You become anxious and frightened, and again, your breathing's exacerbated. And these are all things that we can look at as we go through these slides of what we can do for these patients. Chest secretions are common in respiratory disorders, but we certainly know now from COVID-19 that these patients produce copious amounts of chest secretions. So you might have seen footage of patients being nursed face down, slightly tilted to help with the expectoration of those secretions. So certainly in my end-of-life patients, I use a lot of drugs such as hyoscine, those sorts of things to help dry up or reduce those secretions. And it may be in these cohort of patients that some of these drugs may not be as effective, but we can certainly try to improve them and make people more comfortable. If somebody does sadly approach end of life from COVID-19, again, there's all the usual kind of symptoms just from a palliative point of view people might experience. So terminal agitation, nausea, vomiting. So again, these are all things that we need to think about in advance for these patients. And I think the emphasis for me is it's not just about patients who may sadly lose a life to this, it's about all the larger group of people who will have symptoms but will recover. So all these people can benefit from what we're going to go through. And I would keep a really open mind because understandably, some of the drugs that I'll mention, you may not use on a daily basis. So things like morphine, lorazepam, other benzodiazepines, but they could be so helpful to this larger group of people who will recover. So again, just because I'm palliative doesn't mean to say I'm just breaching this at just people who sadly might lose their life. So one of the things I wanted to talk about is that some of you may or may not have seen this. NICE produced some guidance a few days ago on COVID-19. And the main thing I kind of want to focus on is this group of how we begin to have discussions with patients that may not benefit from escalation. And if we've deemed a patient not to be for escalation, then how we're going to manage those patients. So the column we're going to look at is this one here, where we've found that critical care may not be appropriate in those sets of patients, then what we're going to do. And understandably, it's very hard to make a decision about who is and who is not for escalation. And a lot of you do that in your job now. We look at who's offered chemotherapy, who's offered radiotherapy, if surgery is appropriate for somebody, if they're fit enough. So they are decisions that you already do, but understandably, they may be done now on a much bigger scale and much quicker because we're not going to have the time to see if this patient is going to get better or not. So it's going to push us out of our comfort zone. A huge part of my job is asking patients about, sadly a part of my job is looking after people with life-limiting illnesses. And when I have those discussions, it's amazing how many don't want things to be done. So actually there may be a large group of patients who are frail, they've got other comorbidities, and when you explain that they may be ventilated for a very prolonged period of time, they may not even want this. And that's part of, my role today, to say include the patient in those discussions. You're absolutely right, it's not just about that clinician. The patient needs to be involved in that because they may not want those things anyway. They advise that anybody over the age of 65 that comes into hospital should have a clinical frailty score done. So this is how they categorise it. So anybody who scores essentially 5 and above, those are the patients to have the discussion with. So it's not saying at 5, those patients, if they hit 5 in that criteria, they don't get escalation or ventilation. It's about saying anybody above that criteria, those are the patients to start having those conversations with. What would you like? What wouldn't you want to happen? So it's just to make people think, actually, this is somebody who actually would benefit from those discussions, and then actually they may not want things to be done. Obviously the challenge then does arise if they do, but at least have those discussions with the patient. And I think a lot of people really struggle with those genuine good communication discussions. People find it very hard. And I think because I do it on a more regular basis, it's probably easier for me to say that, but I appreciate for people who don't do it every day, it does feel uncomfortable and it can be really challenging, it can be exhausting emotionally. And I think to do this then on a much bigger scale than anyone's ever used to, potentially, it is going to be hard. And that's why we all need to kind of work together and to support one another in these decisions, but with the patient as the centre point. So anybody that under NICE guidance at the minute, anybody who scores a 5, they're the ones who should trigger that initial discussion about, is this person suitable for escalation and ventilation? So I'm just going to go on to another document now based on that. So what we decided to try and do to help them people in that locally is to come up with a little bit of guidance, and it is guidance. That's what I must again emphasise. It is not a set protocol, it is just guidelines to help support you in decision making. So based on NICE, we know that anybody who scored 5 and above, we should be having those discussions. Now we know that time is critical in COVID-19 patients because they can deteriorate quickly. So for most of us, we get an unwell patient to the ward. Maybe they're still for escalation, they're still for resuscitation. We might wait a few days to see, are they improving, are they deteriorating? And then maybe if they're not getting better, we then make that decision with the patient about resuscitation. We might not have the luxury of time in these patients. So actually, you might be having these discussions far earlier than you ever would do in your normal clinical practice. And again, that may feel really uncomfortable. But we know if you don't do it sooner, you may lose the opportunity. And I'm sure you've seen potentially some of the Resuscitation UK guidelines that again have come out in the last few days with COVID-19 positive patients. If they do have a cardiac arrest, the whole team needs to be gowned up in full protective gear. That delays the onset of CPR, and we know for effective resuscitation, the sooner you start it, the better. So there's a potential there that those outcomes are going to deteriorate just because of the environment we then find ourselves in. So we need to make sure if we're going to do things like ventilation, like CPR, that those people are going to benefit as best as they can from what we're about to do to them. So what we felt was, to give a bit of guidance, is we've now identified this cohort of patients. They are more frail, they're more vulnerable, maybe they have carers, maybe they start to need more assistance, they've got lots of underlying health conditions. Start to have those discussions with them. Start to find out what would you want if you deteriorate, because that will help guide you. They also challenge in that is that their loved ones will probably be self-isolating because they may well be positive too, they've come into contact. So our normal way of communication, again, will be altered. So normally we arrange a time for the family to come in, we sit and have those discussions, all lovely, organised. This will be done far quicker. You may have to ring a next of kin over the phone. It is going to feel uncomfortable, but that may be the situation we find ourselves in. So certainly have those discussions early. You've then identified your patient, you've had that discussion, and maybe with the patient's consent, they agree they wouldn't want to be escalated and they wouldn't want resuscitating if their condition were to deteriorate. We're now faced with a patient in hospital that most likely we can't move anywhere else. Their nursing home probably won't accept them back because they're positive. They probably can't go back home because who's going to help to care for them? So potentially, if they're here, there may be no other option for them to go elsewhere. So then what do we do? So I think from a ward-based point of view, it's then having those thoughts, right, we know they're for ward-based care, they're not for escalation. They may improve, but they may not. Are we going to continue doing things like observations? Is that going to help us with this patient? Is it going to change their management? And I think anything we do moving forward is about what's going to help that patient. They may be on oxygen, but just because they're on oxygen doesn't mean to say we need to check their oxygen levels. Maybe it's more about changing it and asking the patient, is that oxygen helping you? Do you feel less breathless? And actually, if they don't, maybe wean it down. So it becomes less about the numbers, but more about what makes that person comfortable. And then blood tests. In these patients, maybe they don't need blood testing, because again, is it going to change any of your management? And it probably isn't. Now, that's not to say that if they improve over the coming days, you may then reinstigate all of these things, but it's just thinking that potentially wards could be very busy. They need to know who needs observations doing, who doesn't at the minute, who maybe doesn't need blood tests at the moment. So everybody has got a really clear plan. Everybody on that ward knows who's having what, and it's that good communication. So we need these decisions made early, quickly, and then everybody's very clear. At this point, I would then say, if you now have this patient who is not for escalation, they're not for resuscitation, we've made the decision for now, we're going to stop observations and bloods, I would be encouraging everybody to prescribe preemptive medication, because we now don't know when this patient or if they will deteriorate. And it is so much better practice to have those medications prescribed and available than that patient deteriorate, everybody's very busy and a staff nurse is trying to get hold of somebody to prescribe something. So it's much better practice to have it all prescribed, and if they never need any of it, then brilliant. But if they do, it's there and available to be given straight away. And again, that may be uncomfortable for some people to be prescribing these drugs, what they feel might be earlier than needed, but it's better to have it there and never needed than not have it, and then somebody's waiting and distressed. And we'll go through the drugs as we go through. So in an ideal world, as I mentioned, you might give patients other opportunities. Do you want to go home? Do you want to come to the hospice? Do you want to be in 24-hour care? It may not be possible for these patients to be moved, but what I would say is keep an open mind. Things may change over the weeks and months depending on what does or doesn't happen, but I suspect for the short term, patients will probably be here to stay, but that could alter. So we do recognise this is going to be difficult for a lot of people who maybe haven't worked on clinical areas for some time, drafted into work on wards, they're going to feel out of their comfort zone. And I would encourage anybody to use the palliative team. Their contact numbers are there, we will reiterate that repeatedly. There's a team based here, and I think as a team, because we cover the hospice, we cover the community and hospital, we will put our resource into where we're needed. So if it's here that we need to be, then more of us will be here. And if you're not sure, pick up the phone and ask. We might not be able to see every patient, but we can certainly provide advice. So if you're giving medications and you feel they're not effective, then we can support you in changing those doses, trying other things. So please use us, that is what we're there for. So in terms of symptoms control then, I would strongly advise orals and subcuts. And a bit like I mentioned earlier, the reason for that is we do not know when that patient will deteriorate. Just because they can swallow now, they might not be able to several hours or days later. So to have both readily available, it provides less delay to the patient in getting drugs that may help them. Again, just because the patient can swallow, when you're very breathless, trying to take medication when you're breathless can be really difficult. So don't be afraid to give something subcut, even if they can swallow, but just because they might find it really difficult to coordinate themselves. So sometimes we use subcutaneous drugs in patients such as MND, not just because of lack of swallowing, but if they can swallow, just because that trying to negotiate, trying to take your breaths in with trying to swallow, it can be really difficult. So if you're unsure, please ring, but don't be afraid to go for a subcut over an oral just because you're worried about giving an injection. You will not harm the patient. What will harm the patient is not getting something that can ease their suffering and their symptoms. So from a symptom point of view, the first thing being breathlessness, which we anticipate for obviously the vast majority of these patients. If they can swallow and they're able to do so safely, Oromorph, which is an oral liquid version of morphine. People worry when we mention morphine in breathing disorders. They worry that in the literature you get it out and it says it can cause respiratory failure. To a certain degree, we're trying to reduce their respiratory drive, because if you reduce their respiratory drive a little bit, they will feel less breathless. They can take a bigger breath in, they can oxygenate better. So actually it helps them in small doses. And a lot of patients we care for with things like pulmonary fibrosis and COPD, we give them Oromorph, not for pain, but for their breathlessness. Now, a patient may be breathless all the time, but you'll also find, particularly for nurses and healthcare assistants, when you provide their care, you move them, wash, stress, they will get a lot more breathless with minimal movement. So you can give these drugs before you do their cares, before you move them. And again, it may mean organisation on a ward to know that patient needs some care. Let's give them some Oromorph and we'll go back 20, 30 minutes later and do their care. But actually, they'll be a lot more comfortable by having that drug before you do their care. So it's just thinking of those additional things that may be different to your normal practice. If for any reason they can't take morphine, whether they've got an allergy or a sensitivity, then oxycodone is another drug of choice which you can use. They're going to feel very anxious, they're going to feel frightened, so we anticipate things like lorazepam will be really helpful. And you can use that in combination with Oromorph. So again, for a lot of my patients, I will give them together and they get the added benefit from both drugs. So again, don't be afraid to do these things. And if you are unsure, phone and ask. Drugs, other comorbidities, they might get delirious. So again, things like haloperidol may be very helpful in this situation. And again, this is not just for patients who may be end of life. It may be with those with really significant symptoms who may well improve. And what I try and do as an analogy, we get patients come in with fractured ribs. We give them morphine so they can breathe deeply, they can cough, so they don't get an underlying chest infection. But then they go home without morphine. So it's just a temporary solution to help them. And I treat some of these patients just like that. It's a temporary thing, hopefully, to ease their symptoms, and then we'll wean them off of those medications. And again, we can assist with that, and then hope they'll go home. We thought we'd provide a little bit of guidance on just titration of opiates, because it might be something that you have to do a little bit more often, potentially, if you're giving drugs and they're not benefiting. So we always say to take into account any additional opiates they've had in addition to their background. So just for example, if somebody's on Zomorph at 10 milligrams morning and night, their total 24-hour dose is 20 milligrams. Maybe the last 24 hours they've had 2.5 milligrams of Oromorph, so that's another 10. You'd add the 10 onto the 20 and then split the dose of 15 BD. So it's quite as simple as that. Just add on what PRNs they've had onto their background and adjust the dose. The PRN dose should be 1/6 of the total dose as a rough guide. That's normally what we would use. So if you do have to increase the background opiate requirement, just make sure you increase the PRN dose to keep it in proportion, otherwise it doesn't become as effective. It's worthwhile considering non-pharmacological measures. So things like if you've got your patient who is still alert, they're sat up, get them in a good position, get them sat up, give them a pillow to hug, good positions can really help with their breathing. So it's worthwhile using non-pharmacological things. Normally in our patients would advocate things like a handheld fan, because that's quite good evidence for that to show that it reduces breathlessness, but we know we cannot do that with COVID-19 patients for obviously the spread of infection. Things like a nice cold cloth on their forehead, if they're pyrexial, remove the amount of bedclothes, just simple things, but they can make people feel more comfortable. And then coming on to the subcutaneous ones, doses and medication. So again, it is good practice to prescribe both, and then hopefully you may never need any of them, but at least if you need some, they're there ready and waiting. So because we have a supply shortage here at the minute of diamorphine, the Trust is using morphine sulfate as their primary choice of opiate. And it's just half the dose of their oral. So again, very easy conversion, just 50% of the dose given as an injection. But again, if anybody can't tolerate morphine, you use your oxycodone as your second line. Midazolam we think will be very helpful. We use a lot of that in patients with end-stage respiratory disease. So for example, if they can't take lorazepam, they can have a little bit of midazolam just to make them feel more calm, relaxed and more comfortable. Haloperidol, just as we did orally, we use the same dose as we do subcutaneously. With regards to the airway secretions, we do know that they produce copious amounts of secretions. I think what I would say from my experience is if you sadly have somebody who is end of life and has a lot of chest secretions, they're normally in a very deep sleep. They often are not aware of those secretions. And actually the hardest thing is for their loved ones who normally sit around hearing the secretions, but not for the patient. So if you give drugs and they're not working for secretions, but the patient looks comfortable, they don't look distressed by it, they're not trying to cough, they're not trying to swallow, that is okay. It's more sometimes about making us feel more comfortable. But actually, if they are really settled, we might just have to accept that maybe people will have more secretions. And again, sometimes positioning can help with that. Slight side tilts, head tilts can just help to drain some of that. On the intranet, under divisions, if you go to integrated medicine at the top and then select palliative care, there's a whole host of algorithms on there for all the different symptoms with a lot more detail. So if anybody wants more information, the algorithms are on there under divisions and then integrated medicine and palliative care. And for each of these main symptoms, you can follow the algorithm if you want more information. For those of you who are going to prescribe, it's worth noting, for those who don't know, that on Meditech, there are now preemptive drugs set up as a set. So you don't have to go through every drug individually. And this is something I learnt yesterday on Meditech, is on here, I would normally log on to Physician Care Manager. There's a practice ward. So if anybody's unsure about prescribing, you want to practice on a patient without hurting actually somebody in real life, you can go on PCS status board. In there, under lists, or locations, there is a training ward, which is training ward A4. There's about 6 practice patients on there. It may be worthwhile, if you're unfamiliar with any drugs, just going on to those patients and you can practice. You can put them on, take them off, discontinue. So if I just select one as an example, we can go to orders. We can then go to new set. And under name, if you just start to type in PRE for preemptive drugs, you will see preemptive medication is there in that list. If you then click next, it will bring up all 4 drugs I've just referred to: morphine, haloperidol, hyoscine and midazolam. And all you have to do is click each one and then click submit. The doses are pre-populated for you. The only one that you might need to amend is the midazolam, which is just set at 2.5. And we normally advise a range. And the reason for that is, again, when people are very busy, maybe a staff nurse has tried 2.5 a few times, patient's still not really comfortable. If we put 2.5 to 5, it gives them that opportunity to increase the dose without having to get somebody to come back and immediately review. So at least the patient can access some more medication. So they're all in there, pre-populated. You just select them and then click submit. The other thing in there is also syringe drivers. Here we go. So under new meds and then name, again, you can automatically see a syringe driver. So then all you have to do is add into that the drugs, and then normally water for injection is your dilutant. So again, there are things set up on there if you aren't aware of it, just to make life a little easier for you, because we appreciate that we may or may not be busy. So these are guidelines. They're going to be available to everybody. They'll be on the intranet. I think most wards are planning on printing a copy out, and it's just double-sided with the flowchart on the first page to encourage discussions, and it is discussions. And then on the second side about how to manage some of those symptoms, and then with our contact details. And I would encourage you to use us, use our services. We will be there to support you, because we do appreciate this is difficult. And just for, I guess, for staff information, there's a lot of work going on nationally about how staff will be supported potentially at the end of all of this. There's a lot of work with Hospice UK and bereavement services, because we appreciate not just patients and relatives, but staff may need support. And I think the other thing to recognise is relatives, their bereavement is going to be so different at the end of this. Now they get to sit with their loved ones, hold their hands, spend those last hours and days with them, reminisce around the bedside, and now they're not going to be with that person. They'll be on the end of a telephone. They won't be there to say their goodbye. So these relatives are going to struggle hugely and immensely. And for us to try and show a bit of empathy, even if it's down a phone call, may make the world of difference to these individuals that are going to be impacted by this. So I would encourage you to do whatever you can to support each other, relatives, patients, because we're all going to need each other. And I think there's going to be a lot of challenging times ahead for us all. So if anybody's got any questions on what we've talked through, then please let's work through them.
So what was the syringe driver for?
Yeah, so the syringe driver was if you're using, say if you get to the point where you've used multiple or regular subcutaneous doses, say for example in the last 24 hours patients had 3 or 4 doses, you may want to move to a syringe driver so they've got constant background, either analgesia, whether it's midazolam, to keep on top of their symptoms. Because you often find if you start giving repeated doses, you give the dose, symptoms are managed, as the dose wears off, symptoms recur. So if you get to a point where you're giving 3 or 4 doses in a day, that patient would be better having a constant background dose to keep on top of their symptoms. So certainly syringe drivers in repeated doses of PRNs are really helpful to manage symptoms. The one thing that we sadly do know from some evidence so far is that because patients can deteriorate quickly, we may not use as many syringe drivers as we initially anticipated we might need to use, but some patients may still need them potentially.
So to start with, we prescribe the oral
and subcut.
And the syringe driver.
So don't prescribe the syringe driver first, just start with oral and subcut, but then if somebody's needing repeated doses over the following day, then I'd probably say to contact us and we may suggest a syringe driver.
Yeah. Just another question about, usually when we prescribe the preemptives,
yes,
a lot of the effect of morphine would be to limit breathing, and this can lead to potential carbon dioxide and accelerate death. So we usually take a decision to prescribe them when we think the patient is already at the end of life pathway. But you're advising to now start it even if you're still active.
Absolutely. I use morphine in patients who might have 6 to 12 months to live at end-stage COPD, pulmonary fibrosis, and they can be on it for months of their life because it helps their symptoms, because you're giving it in a small dose that does not cause respiratory depression. So there's a huge, I think, misconception around people about you cannot give morphine or opiate products in people with respiratory distress, but you really can. You know, a lot of patients out in the community, I advise them to use it in the morning before you get out of bed, because you know when you get out of bed you'll be very breathless, you're going to get washed and dressed, and that will make you breathless. Have a dose before you get out of bed and you will feel more comfortable. So the doses that we are recommending, it will not impair their respiratory function, it will just make them more comfortable without suppressing it.
And regarding that frailty score, so
yes.
If the frailty score is above 5, so these patients should not be escalated, yeah?
No, it's not about yes or no escalation. It's about if they score 5 or above, those are the patients to start having the discussions with, to see what they want and to see whether you feel they're appropriate. So it's not a yes or no. It's just that, I think it's just to try and identify which patients are the suitable ones. So you've got to put a score somewhere, but it's not about yes or no. It's about, we recognise that these people score 5 and above. We should now start to have a chat with those people. What would you want to happen?
Okay. Because I think there was another meeting a few days ago among the clinicians, and they said that if the frailty score is above 5, then these patients should not be resuscitated and should not be...
Absolutely not, and that would be against all guidance. So the NICE guidance clearly states if they score 5 or more, and it means if they are deemed critical care is not appropriate, there's almost a step missing there, but if you read the guidance, that arrow in between that, it states to have a discussion and then if they're deemed not appropriate. So all the 5 is saying is these are the people you now need to start thinking about. And we all know whether when CPR is performed, we fill in the pro forma at the end. Should this patient have been resuscitated? And we all know that there is a group of patients that we shouldn't be doing these things on. And all it's saying is to think about it, be more open in discussions, and have discussions maybe sooner than you would have naturally done with patients.
And if the frailty score is higher, like let's say 6, 7, above that, if there any frailty score where we don't need discussion with the family and we make decision of our own in urgent situation? I know it's difficult.
I would never advise, well, I appreciate there may be circumstances where you have to make decisions very quickly. And I would say if you have to make a decision quickly, then you, at the most convenient time, you need to communicate that to their loved ones and their next of kin. Because ideally, this needs to be a discussion with the patient and or their next of kin. So yes, you may have to make decisions quickly, but then you need to communicate that very quickly.
Obviously communication, but prior to communication, I mean, for example, I am in the research, a patient has come, and the frailty score is 7 or 8 or something like that. And we need to make a decision at that point, and we make a decision and then communicate with the family or the loved ones. But my question was that is there any cut-off level?
No, absolutely not. And I think the other countries that have been involved in this prior to it coming to ourselves have felt that you just can't do that. You cannot say this person cannot have this treatment. It's about discussing it and trying to come to the best decision that you can do. But you cannot set a cut-off. And we don't do that, do we? In general clinical practice, we do it as a discussion. We try not to say, you are not having this treatment. We try and make the person feel involved in that decision. Okay, well, I hope you found it helpful. I appreciate it may generate more questions to come. So please contact us if there are other things. And yeah, thank you for listening.
Thank you.